disease, WD, is a genetic metabolic disorder inherited in an autosomal recessive pattern and is classified under IEM, inborn errors of metabolism diseases related to metal metabolism. It primarily manifests as liver damage and neuropsychiatric symptoms. As the disease progresses, nearly all patients develop psychiatric symptoms, including depression, anxiety, impulsive behavior, or cognitive impairment. Studies show that around 20% of patients have seen a psychiatrist before diagnosis, and 30 to 40% already show clear psychiatric symptoms at the time of diagnosis. These symptoms are nonspecific, often leading to misdiagnosis as depression or schizophrenia. Therefore, understanding the psychiatric symptoms of Wilson disease is crucial for early identification and to avoid the inappropriate use of antipsychotic medications. Wilson disease is caused by a mutation in the ATP7B gene, which leads to a failure in copper elimination. This results in copper accumulating in organs such as the liver, brain, and cornea, causing liver disease, neurological symptoms, and psychiatric disorders. The psychiatric symptoms in Wilson disease are linked to the buildup of copper in the brain. Common manifestations include basal ganglia, frontal lobe pathway damage, leading to personality and behavioral changes like irritability, impulsivity, and social withdrawal, and mood disorders such as depression and mania. Damage to the basal ganglia and subcortical structures, leading to cognitive impairment, such as problems with attention and memory. Some patients, due to damage in the amygdala and prefrontal cortex, may also experience anxiety, compulsive behavior, or even psychotic symptoms, such as auditory hallucinations and delusions in severe cases. It's important to note that psychiatric symptoms in children may present as learning difficulties and impulsive behavior, while in adults, they are more likely to appear as personality changes, anxiety, depression, or cognitive decline. Therefore, early recognition of psychiatric symptoms in Wilson disease is crucial for timely diagnosis and treatment. Case study of Wilson disease, WD. A 37-year-old woman with Wilson disease. She had no significant medical or psychiatric history, but there was a family history of psychiatric disorders. 4 months ago, she started experiencing clear symptoms of depression, including emotional blunting, fatigue, slowed speech, and tremors. Initially, she was diagnosed with reactive depression and treated with fluoxetine. However, her symptoms didn't improve, and she developed suicidal tendencies, ultimately requiring hospitalization. During her hospital stay, her symptoms did not improve, and she developed extrapyramidal side effects. After a series of tests, doctors found that her ceruloplasmin levels were low and her urinary copper levels were elevated, leading to a diagnosis of Wilson disease. After starting copper chelation therapy, her psychiatric symptoms improved rapidly, and her motor symptoms gradually began to improve as well. After 1 year of treatment, her psychiatric symptoms were completely resolved, and her motor symptoms showed significant improvement. She was eventually discharged and continued follow-up visits at a neurology clinic. 18 months later, while she still had some ataxia, her psychiatric symptoms had fully recovered. This case serves as a reminder that the neuropsychiatric symptoms of Wilson disease can often be misdiagnosed as psychiatric disorders. Early diagnosis and copper chelation therapy are crucial and can significantly improve a patient's quality of life. Case study of Wilson disease, WD. A 42-year-old man with Wilson disease. The patient was initially referred to internal medicine after experiencing tremors and an inability to walk for 6 to 7 months. He had previously been misdiagnosed with schizoaffective disorder by a psychiatrist and was treated with valproate and olanzapine. Although some symptoms improved, his tremors and wandering symptoms persisted. As the condition progressed, the patient switched to risperidone, but his symptoms worsened with the addition of full-body tremors and drooling. He was ultimately referred to a medical clinic. After a neurological exam, he exhibited muscle rigidity, tremors, and speech difficulties. An eye exam revealed the classic Kayser-Fleischer rings, a key diagnostic sign of Wilson disease. Laboratory tests showed that his ceruloplasmin levels were low, and his urinary copper excretion was elevated, confirming the diagnosis of Wilson disease. The patient began treatment with zinc sulfate and olanzapine. After 4 months, his psychiatric symptoms and tremors significantly improved. 18 months later, his ceruloplasmin levels returned to normal, and no liver or kidney damage was detected. This case highlights how the psychiatric symptoms of Wilson disease can easily be misdiagnosed as psychiatric disorders. Early copper metabolism testing is crucial for timely diagnosis. Diagnostic tips for Wilson disease, WD. First, be aware of atypical psychiatric symptoms. Wilson disease often presents with depression, anxiety, personality changes, or psychotic symptoms as the initial signs, even before liver disease or neurological symptoms appear. When psychiatrists encounter a first-time psychiatric disorder in young or middle-aged patients, especially those with unexplained tremors or ataxia, Wilson disease should be considered, and copper metabolism testing should be conducted. Ceruloplasmin levels and 24-hour urinary copper excretion are crucial tests for diagnosis. Typically, Wilson disease patients have ceruloplasmin levels below 20 milligrams per deciliter and urinary copper excretion over 100 micrograms per 24 hours. If ceruloplasmin is below 20 and urinary copper exceeds 70 micrograms per 24 hours, the diagnosis is highly specific. The Kayser-Fleischer ring seen during an eye exam is a hallmark of Wilson disease, especially in patients with neurological symptoms, where detection rates can be as high as 90 to 100%. MRI and ATP7B gene testing also help confirm the diagnosis. It is especially important to avoid the misuse of antipsychotic medications, as Wilson disease patients are sensitive to dopamine receptor antagonists, which can cause severe side effects. In treatment, chelating agents like D-penicillamine are the cornerstone, but early treatment should be approached with caution to prevent worsening of neurological symptoms. Finally, early diagnosis and treatment are critical for improving prognosis. Copper chelation therapy can improve most psychiatric symptoms within weeks, preventing irreversible brain damage and significantly improving quality of life. Neuropsychiatric symptoms and molecular mechanisms of Wilson disease, WD. Wilson disease, WD, is caused by a mutation in the ATP7B gene, leading to copper metabolism imbalance and resulting in neuropsychiatric symptoms. Due to the nonspecific nature of these symptoms, they are often misdiagnosed as primary psychiatric disorders. The neuropsychiatric symptoms of WD are related to various factors, including copper toxicity, oxidative stress, mitochondrial dysfunction, neurotransmitter imbalance, neurotrophic factor abnormalities, immune inflammation, and hepatic encephalopathy. These mechanisms collectively impact brain function, leading to a wide range of psychiatric symptoms. Copper toxicity and oxidative stress. Copper is an essential trace element in the brain, particularly concentrated in the basal ganglia, hippocampus, and cerebellum. In Wilson disease patients, free copper levels in the blood rise significantly, making it easy for copper to enter the brain and trigger oxidative stress. Free copper has strong oxidative properties and can generate reactive oxygen species, ROS, through the Fenton reaction, leading to lipid peroxidation and damage to DNA and proteins. Studies show that the oxidative stress and neuroinflammation caused by copper accumulation are key mechanisms behind the psychiatric symptoms in Wilson disease. Excess copper activates NMDA receptors and glutamate pathways, leading to excessive neuronal excitation and cell death. Astrocytes protect neurons in the short term by buffering excess copper, but with long-term copper overload, astrocytes begin to malfunction, disrupting the blood-brain barrier. Additionally, free copper triggers the release of pro-inflammatory cytokines, such as interleukin-6 and tumor necrosis factor alpha, which intensify neuroinflammation. Neurotransmitter imbalance. Copper is a cofactor for enzymes like dopamine beta-hydroxylase and tyrosine hydroxylase. Copper overload disrupts the synthesis and metabolism of dopamine, norepinephrine, and serotonin, leading to mood swings, attention deficits, and impulsive behavior. At the same time, oxidative stress caused by copper also affects neurotransmitter storage and reuptake, further disrupting emotional regulation. Mitochondrial dysfunction and cell death. In Wilson disease patients, free copper can enter the mitochondria, damaging the electron transport chain, reducing ATP synthesis, and increasing the production of reactive oxygen species, ROS. Studies have found that copper and iron metabolism dysregulation can trigger two novel forms of cell death, cuproptosis and ferroptosis. Cuproptosis is caused by copper accumulation, leading to the buildup of lipoylated proteins and loss of FES cluster proteins, resulting in mitochondrial degeneration and membrane damage. Ferroptosis is characterized by mitochondrial shrinkage, increased membrane permeability, and iron-dependent lipid peroxidation. These mechanisms have mainly been verified in animal models and have not yet been confirmed in clinical settings. Neurotrophic factors and ATP7, B-specific protein. Copper overload inhibits the production of neurotrophic factors like BDNF, brain-derived neurotrophic factor, and NGF, nerve growth factor, which are critical for neuron survival and synaptic plasticity. Increased copper levels may reduce the activity of these factors, leading to neurodegeneration and mood disorders. Additionally, pineal-specific ATPase, PINA, an isoform of ATP7B, may affect the secretion of melatonin, which can disrupt the circadian rhythm, causing sleep disturbances and depressive symptoms. Immune/inflammatory response and non-coding RNAs. The inflammation hypothesis of mental disorders suggests that oxidative stress and immune activation may promote psychiatric conditions. Copper accumulation increases the levels of inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha in the striatal region of the brain, and raises the proportion of peripheral immune cells in neuropsychiatric patients, which correlates with the severity of symptoms. Copper-induced oxidative stress disrupts the blood-brain barrier, activating microglial cells and triggering neuroinflammation. Furthermore, non-coding RNAs, such as miRNA, lncRNA, and circRNA, may play a role in neurodevelopment and memory formation. Studies of Wilson disease animal models have shown that several non-coding RNAs contribute to the development of cognitive impairments and psychiatric symptoms, providing new molecular insights into the understanding of Wilson disease-related psychiatric disorders. Neurostructural damage in Wilson disease and its impact on psychiatric symptoms. 1. Basal ganglia and brain structural damage. Neuroimaging and pathological studies show that Wilson disease primarily affects the basal ganglia, especially the putamen, globus pallidus, and substantia nigra, as well as the thalamus, cerebellum, and brainstem. The neurons in the basal ganglia are rich in copper, and copper overload leads to neuron death and glial cell proliferation, causing motor disorders and psychiatric symptoms, commonly including depression, anxiety, and executive dysfunction. Copper overload also disrupts the blood-brain barrier, leading to copper deposition in areas like the basal ganglia, thalamus, and substantia nigra, resulting in necrosis, glial cell proliferation, and neuron loss. Copper toxicity further inhibits neural pathways between brain regions, leading to chorea-like movements and other movement disorders. MRI scans typically show T2 high signal or T1 low signal/atrophy in the basal ganglia and thalamus, helping assess the extent of copper deposition. Damage to the prefrontal cortex and subcortical structures can lead to declining executive function and emotional disorders, similar to Parkinson's disease and Huntington's disease, explaining the behavioral changes, depression, and mania seen in Wilson disease patients. 2. Astrocyte oligodendrocyte and myelin damage. In Wilson disease, neurological damage is primarily caused by extrahepatic copper toxicity, resulting in significantly elevated copper levels in both brain tissue and cerebrospinal fluid. Initially, astrocytes and oligodendrocytes absorb and buffer excess copper to reduce toxicity. However, with prolonged copper overload, these cells proliferate and undergo morphological changes, ultimately failing to effectively mitigate copper toxicity. Oligodendrocytes experience edema, leading to demyelination. Imaging studies show that demyelination causes white matter damage and myelin thinning, which further contributes to subcortical dysfunction. These glial cell pathologies are closely linked to cognitive impairment and psychiatric symptoms. 3. Hepatic encephalopathy and the liver-brain axis. In Wilson disease, severe liver damage can lead to portal systemic shunting, allowing neurotoxic substances such as ammonia and manganese to enter the brain, causing mild hepatic encephalopathy. Research shows that some patients' neurological symptoms are related to hepatic encephalopathy, often presenting as apathy, irritability, and emotional instability. Therefore, liver function evaluation and monitoring for hepatic encephalopathy are crucial for managing psychiatric symptoms. Wilson disease, WD, is a treatable genetic metabolic disorder, but its psychiatric symptoms are diverse and often overlooked. Any patient, regardless of age, presenting with unexplained depression, mood swings, personality changes, or behavioral disturbances, especially with liver dysfunction, tremors, or ataxia, should be considered for copper metabolism, evaluation, and eye examination to detect Kayser Fleischer rings. In treatment, copper chelation therapy is the cornerstone of management, and zinc salts or other chelators may be added if necessary. Early diagnosis and individualized treatment are crucial to significantly improving the patient's liver function and neuropsychiatric outcomes, preventing irreversible brain damage. If you want to learn more about inborn errors of metabolism, IEM, and their connection to mental health issues, specifically metabolic psychiatric disorders, be sure to subscribe to my channel.